the 12 rules to live by for men on testosterone. Rule number 9, prostate health. I'll bet you this video is going to be super important for so many men. However, it probably won't be that sexy and get too many clicks, but that's okay. Because I could tell you, in the end of the day, for men on testosterone, there's 2 organs that are going to be the most important: your heart and your prostate. And of course, quality of life is everything. Of course, the sex is everything, and how you feel is important without having suffering in your life by any means. But not to mention, if you want to live a long life, you have to look at the true data from a public health standpoint of what's going to kill you and what's going to happen to you. So prostate cancer for men is actually the #1 most common cancer for men, apart from skin cancer, right, which is basal cell and squamous cell. So if you live long enough of a man, I could tell you this is going to be something very important for you, not to mention if you're on testosterone. All urologists and all endocrinologists will agree today that testosterone supplementation does not cause prostate cancer. Let's go into prostate cancer. First, guys, I'll leave the BPH and the enlargement of the prostate and lower urinary tract issues for the end of this presentation, because let's go to the most important stuff first, which is prostate cancer. Controversy exists over what happens to a man that has prostate cancer and subsequently starts testosterone supplementation. Does it grow the prostate cancer? Is it fuel to the fire for prostate cancer? Remember, you have to understand evidence-based data is king, and this is something that is controversial right now. Again, no one's going to argue if you don't have prostate cancer when you start testosterone therapy, it's not going to cause prostate cancer. And we're going to talk about the data on this. But if you have even a tiny bit of prostate cancer and you give it exogenous testosterone, what can happen? Can it grow it? Controversy, guys, controversy. And here's what I want you to understand. I have seen, however, a small number, super small, out of thousands of patients, I've seen a handful of men, 45 to 60 years old, that started testosterone. Of course, they needed it. They had low testosterone. Maybe they did some steroids. Maybe they just had metabolic disease and they had low T. And we looked at their PSAs in the beginning. It was low. They were under 4. They might have been under 1. They might have been something under 3 nanograms per milliliter. And they had a digital rectal examination and they didn't have any prostate cancer. Now, subsequently to starting testosterone, under my monitoring, in the course of 18 months, I watched the PSA go up, 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 and away. And they had no symptoms. I made appropriate referral to urology, and subsequently they've had biopsies and they were diagnosed with legitimate prostate cancer. This is super rare. I want to tell you the truth, super rare. However, you have to monitor for it. Now, what's going on with the current data that indicates... Hey guys, quick pause here. If you're watching this video, odds are you're concerned about your testosterone levels. That's where the sponsor of this video comes in. Let'sGetChecked.com. Let's Get Checked makes professional health testing easy by letting you get tested without having to visit a healthcare provider. Choose your test online, like one of their testosterone panels, and it will be delivered to you in discreet packaging with next day delivery. Once your sample arrives in a laboratory, confidential results will be available from your secure online account within 2 to 5 days. See my link in the description for more details and discount code. What's going on with the current data that indicates that most men, and actually this is emerging data now, men that are on testosterone, they're on it long enough, 5 years, 10 years, the data is not great. It's retrospective, it's meta-analyses, it's not randomized, double-blinded prospective data, but it looks like today that men that are on testosterone, if they don't have prostate cancer, it appears that those men are protected from developing prostate cancer. And I can tell you this, that they have a lower incidence of prostate cancer. There's studies on this now. And that if they do develop prostate cancer, it appears like it may be a less malignant type of prostate cancer. Now, what's going on with this? This is absolutely mind-boggling. It goes against the thinking, certainly decades ago, that if you start testosterone, sir, you're going to develop prostate cancer, almost like a guarantee, decades ago. That was cringy and embarrassing because it was based on such limited data, and it was certainly wrong. And now today we have this, which looks like the opposite. So what's going on? Here's what it is. Testosterone saturation model. This is a doctor at Harvard, Dr. Morgentaler, and he has looked into this. And you could research his name, and you could research testosterone saturation model. What's happening hypothetically, because we don't really understand it. Theoretically, the prostate has receptors, prostatic tissue, that can be cancerous like any tissue in the body. There's androgen receptors in the prostate. Somehow, when they're under the influence of exogenous testosterone, they're stimulated, and there's some change, a molecular change with that receptor, with stimulation of exogenous testosterone, not endogenous, not your own testosterone, and certainly not low testosterone with men that are getting older. And with this, there appears to be data that supports that there's some protection of testosterone upon the prostate. We don't know. It's amazing, and there's more work that needs to be done on this, but it is cool and amazing that this is what's going on. Certainly, I've been on testosterone for 30 years, and I watch my PSA with the grace of God. It's under 1, and the digital rectal examinations are normal, and I feel fine. Now, bodybuilders don't die from prostate cancer, right? Of course, you're going to see 1 or 2 that may have died, but is it because from testosterone or steroids? The answer is no. Men, if they live long enough, they're going to get prostate cancer. Most don't die from prostate cancer. Yeah, interesting public data, public health data. So, what can you do if you're on testosterone? I want to give you some actionable information. You're on testosterone. How are you going to monitor your prostate? Most importantly, for prostate cancer, number 1. So evidence-based data speaks. You need to look at your baseline PSA. You know how many times guys come into me, they're on testosterone, I ask them, well, where's your PSA? They don't even know what it is. It's not even been checked. That's cringy. Cringy and embarrassing. So don't do that. You need to get a baseline PSA. You don't need a free... When you are a normal man and you don't have prostate cancer, and your PSA is under 4, you should not be getting detailed analyses, assays of a free PSA numbers. Total screening PSA is adequate. It is an apple and orange. There's different assays. Try to keep the assays tight. You also need digital rectal examination, at least initially. Should be done by a qualified healthcare provider that can really feel a prostate through the digital means, rectal means, and differentiate a problem in the prostate. Again, urology doctors are going to be the best. No one's going to compare to a urologist because they own the prostate. That's what they do. They're surgeons. So every 6 months to a year, the PSA should be checked. And subsequently, if the PSAs are low and they're not moving and you have no symptoms and your prostate's fine, it's fine for annually, to do that annually. This is actionable information for you guys. If you have any signs of prostate problems or disease or lower urinary tract infections, you're going to want to obviously see a urologist, and they're going to start checking the PSA, and they're going to start checking for problems, and of course, digital rectal examination. I'd like you to understand something very important. If your PSA goes up, and with or without testosterone on board, go to an expert. urologist in a center of excellence, an academic center of excellence, any place in America or the world for that matter, and find an excellent urologist that's academic, really. And don't just do a prostate biopsy. They're going to repeat the PSA. There's other assays now that can chemically differentiate. Is it enlargement? Is it non-cancer versus cancer? You can't determine sometimes just by looking at that number. So they used to jump right away to a transrectal biopsy. That's painful. It's bleeding. There's side effects, infection, and there's even side effects on your sex. Again, don't do it. If a doctor just jumps on that, argue it, possibly, get a second opinion, and consider a prostate MRI. That's the standard of care now. If you have an elevated PSA, and with or without testosterone, you're going to want to get an expert urologist. And I'm telling you, if they don't get a prostate MRI before doing a biopsy, they're wrong. Wrong. So prostate MRI. Next, apart from cancer of the prostate, which is so important to differentiate, is it a malignancy? Is it an enlargement? We can't tell. You need an expert urologist. I use them all the time. I have a very low threshold to refer and to monitor closely to a center of excellence and an excellent urologist. I have them all over the country and the world, thank God. Apart from the cancer, let's talk about what's going on with your prostate as you get older, not to mention on testosterone. If the PSA goes up, if it's not cancer, what happens? Is it BPH? Pay attention, guys. Is it BPH associated with lower urinary tract symptoms where you can't pee or you can't empty? Is it prostatitis of the infectious type or non-infectious type, like a urinary tract infection or a prostate infection? Of course, from sexually transmitted diseases and from just regular E. coli and just regular bacteria that can just get into the urethra and go north and go up and affect the urethra and the prostate. It happens all the time. So, and prostatitis can just happen spontaneous, just spontaneous prostatitis. It's not from infectious. But this is going to be that lower urinary tract symptom where you're waking up at night more and it's a slippery slope. Maybe it's happening older and it's normal. Are you unable to empty your bladder? It's annoying. It's uncomfortable, this BPH, prostatitis, lower urinary tract symptoms. Trust me. And you can have a trauma to the prostate just by riding the bike and the PSA goes up. Again, this is differentiating. How do you differentiate disease that's not malignancy of the prostate with elevated PSAs and now an enlarged prostate? Guys, I do it every day. I have a very low threshold to refer to urologists, but I have to make a decision. Am I wasting the guy's time? Do I need to refer? And after 20 years, you get good at this stuff. But again, I have a low threshold to say, I'm not sure. At any point, the prostate symptoms are there. Let's bring on board a great urologist. Again, center of excellence. So I can tell you this. Testosterone can certainly worsen BPH and enlarge the prostate. Trust me, guys. Trust me. I know. 30 years, my prostate's changed with the grace of God. It's not prostate cancer, but you're going to be on, and again, this is not testosterone itself. There's DHT-derived drugs. There's Nor19-derived drugs. So it's just androgens. But again, classically, and for this discussion, it's BPH, prostate disease, malignancy versus non-malignancy on testosterone. I want to give it to you. Now, if you have BPH now and you're 45, or I've seen men that are on steroids and testosterone based on their genetics and sensitivities, they've had to have procedures. They have BPH that's symptomatic. They can't pee well, and they don't have urinary obstruction when they're young, but they can. That's typically an older man. You can get uroseptic. I've seen it in the hospital with older men when I was a primary care doctor working in hospitals. So if your prostate's getting affected, you're on testosterone, lower the dose. Guys, you don't want to be on too much. It's another reason to lower the dose and maintain the lowest dose you can for your prostate as you get older. Again, young guys, probably not watching this and thinking this guy's talking a bunch of spiel, and it's not going to happen to me. If you live long enough, it's going to happen to you. I can guarantee it. With or without testosterone, testosterone can accelerate the enlargement of the prostate, no question. Although the data on it, it's very squirrely. But I can tell you clinically that it's certainly true. And the more you use, could get worse. So keep the doses low. Next, I'm giving you actual information on this video. Before you use alpha blockers that good urologists will use, I saw a urologist place one of my men who's in his 60s today on testosterone, on tamsulosin, or they use alpha-sosin. These are two different alpha blockers. They can cause dizziness. They're going to work on the BPH. I'd like to bring to the effect and make a recommendation, medical information for you guys. And it's not advice, but it's information. Tadalafil, which is generic Cialis, is absolutely phenomenal. FDA cleared for BPH. So many doctors don't use it and they don't know it. They use these other alpha blockers that I think are not only they're not that good compared to tadalafil, because tadalafil can work on opening up the prostate, and it's FDA cleared for BPH, restoring flow for a man that doesn't have outrageous obstruction, obviously, at all, and can give great sex and better erections and nitric oxide. So I just want to tell you that. So watch the doses, 2.5, 5 milligrams. Some men even take 10 milligrams or more every day, because you could take it every day just for sex. So be careful with this, work with your doctor. Other supplements that can work on the prostate itself: saw palmetto, beta citrus-sterol, pygym, and stinging nettle. Again, these are some of these mediating through DHT modulation, as I've done other videos with the hair and things. Other behavior modifications that I think work very well: caffeine. A lot of men realize too much caffeine affects the prostate. And over-the-counter decongestants and cold medicines, because they're antihistamines, this is amazing. So when men learn the hard way that when they have a cold, they use an antihistamine or a cold medicine, and they get frozen up, they can't pee. Wow, that's incredible. Those are antihistamine drugs. They're over the counter. So be careful with that. Next, and last but not least, what are the procedures that we know that can be utilized for men that have enlargement of the prostate? They have to make a decision that it's not cancer first. These are why urology doctors need to come into play. Mandatory. So there's a TERP. This is the most invasive and the one that's going to be hopefully utilized in last place. Transurethral resection of the prostate, TURP. That's an older man, in my opinion, that is going to be uroseptic if he doesn't open up the prostate and they bore. It's a roto-rooter. It's no joke. But I've seen some urology doctors do it without using other techniques, even medical techniques like I've discussed with the alpha blockers and the tadalafil, and just changing your behavior, just jumping to a TERP. But that's going to be wrong, guys. Again, guys outside of America, guys all over the world, if they jump on a TERP and a surgical TERP, and if you're not that bad, get a second opinion if you could still pee. And again, be careful. Next is going to be a UroLift, and I'm not for or sponsoring any one of these. UroLift, water vapor therapy. There's a laser, and there are other up and coming procedures again that are utilized. There's even a prostate artery embolization procedure that's utilized. Again, that's typically for older men that are not surgical candidates, and it's better to just cut off the blood flow to that prostate and it will shrink it. Again, this is kind of like guys that are older and they're not surgical candidates. But boy, you want to embolize the wrong artery, woohoo! Your penis could fall off. You could really cause some severe damage. This is radiological, interventional radiology. Boy, you got to be careful. That's it, guys. I hope this was a presentation that didn't bore you too much. It was not too sexy, but in the end, it's going to be sexy because your prostate and sex are interrelated. Let's get the questions. Let's get the comments. Let's crank them out so men in the world that are on testosterone, that are getting older, can really understand this interplay of how important it's going to be and the rules of living on testosterone. And this is the prostate rule. Thank you so much, gentlemen. I really hope this helps.